Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 10th episode of brand new Optometry Series 2.0. I'm very happy to welcome my team member, Ms. Meenakshi. Hi, Meenakshi. Thank you so much for joining. And Anshika ma'am was not able to join today, but we'd like to thank Anshika ma'am also for being the pillar of support. I'm very happy to welcome our moderator for the day, Ms. Roshni ma'am. Hi, Roshni ma'am. Thank you so much for pitching in today as the moderator.
Thank you so much for the invite, and I'll surely try to give more insights on the topic today.
Thank you so much, ma'am. To know more about our moderator, Ms. Roshni, ma'am, I'd like to call upon our MC for the day, Ms. Mahalakshmi, to introduce the moderator in detail.
Good evening, everyone. I am Mahalakshmi, third year bachelor's in optometry student at Dr. Agarwal's Institute of Optometry. We are pleased to welcome Ms. Roshni Sengupta, assistant professor at GD Goenka University. With over 6 years of experience in both academics and clinical optometry, she brings a rich blend of expertise and passion to the field. Previously associated with Susant University, Ma'am is currently pursuing her PhD at GD Goenka University, specializing in low vision and binocular vision. She has impressive academic and research portfolio, having published multiple Scopus and Web of Science Index papers, contributed to book chapters, edited a book, and hold 4 patents under her name. Her contributions have been widely recognized. She was honored with the Bloggers Voice Award by the Vision Science Academic in 2023 and has been a guest speaker on several national and international conferences. We are glad to have you with us, ma'am. Thank you so much for joining. The presenter for today is Ms. Rakshitha, pursuing second year Masters in Optometry at Dr. Agarwal's Institute of Optometry. Ms. Rakshitha, please start your presentation.
Thank you, Mahalakshmi. Thank you, Mahalakshmi. Today's session is on anatomy and physiology of iris and ciliary body. So we can move on to the topic. So the uvea forms the vascular middle coat of the eyeball and the multiple essential roles from controlling the amount of light entering into eye to nourish the retina and maintain the intraocular homeostasis. And understanding this layer is a key to diagnose and manage several ocular diseases, in particularly uveitis, and which can be treated, which can threaten the vision if it is untreated. So the first part, the part of the uvea is iris. The uvea is highly vascular and pigmented layer of the eye lying between the sclera and the retina, and it is composed of 3 distinct structures: the iris, ciliary body, and the choroid. So the iris acts like a camera diaphragm. Start from the first. The uvea is highly vascular pigmented layer of the eye lying between the sclera and the retina. It is composed of 3 distinct structures: the iris, ciliary body, and choroid. So the iris acts, today we are going to, now it is part of iris. So the iris acts like a camera diaphragm controlling how much light enters into the eye. The ciliary body functions like an adjustable lens system, allowing us to focus at the different distance and produces an aqueous humor. Choroid acts as the eye blood supply network and nourishing the outer retina and absorbing the stray of light to maintain image clarity. These structures are not independent but work in harmony to ensure optimal vision. Disorders affecting the uvea can lead to serious complications such as glaucoma, cataract, and vision loss. In next few slides, we will be exploring each of these structures in detail and starting with iris. Iris is a flat circular thin diaphragm located between the cornea and the lens, and it is about 12 mm in diameter and central opening for pupil. And this ranges from 1 to 8 mm depending upon the light and the accommodation. Its thickness varies, and it's thickest at the collateral and the thinnest at the iris root. It is about 1.5 mm from the pupillary margin and marks the division between the two zones of the iris. The one is pupillary zone, another is a ciliary zone. The pupillary zone, the iris inner narrow zone around the pupil. The ciliary zone is the outer bordered zone extending to the iris root. So the pupillary zone is the inner and narrow zone and encircling the pupil, and ciliary zone is an outer border zone extending to the iris root. So now the next is about the surfaces of the iris. There is an anterior surface and a posterior surface. On the anterior surface, the iris displays strips of fudge, and which is a small depression allowing the aqueous humor to enter and exit freely. The contraction furrows appears due to the repeated movement of the iris during the pupil side changes, and radial strikes represent the underlying blood vessels. In the posterior surface of the iris, unlikely the anterior, and it is smooth and heavily pigmented, lying in the close contact with lens and prevent the light scatter. So now we are going to move on to the microscopic anatomy of the iris. The iris consists of 4 major layers: anterior border layer, stroma, anterior epithelium, and posterior epithelium. So in anterior border layer, it is composed of fibroblasts and melanocytes. And the density of melanocytes here determines the iris color, blue or green when the pigment is very minimal, and brown or black when the pigment is abundant. Stroma, a loose connective tissue framework containing collagen fibers, fibroblasts, melanocytes, and blood vessels, and other 2 muscles. The other 2 muscles are sphincter pupillary muscle and dilator muscle. So here the circular muscle band near to the pupillary margin controls the pupil constriction via parasympathetic innervation. Here the dilator pupil is formed by myoepithelial cell arranged radially, widens the pupil under the sympathetic control. So the anterior epithelium continues from the dilator muscle, and the posterior epithelium heavily pigmented columnar cells forming the light observing the layer. So here the picture represents the stroma and dilator pupillae and sphincter pupillae, and anterior epithelial layer and posterior epithelial layer and stroma. The blood supply and nerve supply. Here the iris is supplied by major arterial circle formed by an anastomus of long posterior ciliary arteries and anterior ciliary arteries. The blood vessels are not leaky due to the tight junction forming a part of blood aqueous barrier. So here the nerve supplies are parasympathetic, sympathetic, and sensory. So here the parasympathetic, where the pathway from third cranial nerve ends to the Edinger vestibular nucleus and to the ciliary ganglion, and the target with the sphincter pupillae causes miosis, where the pupil constriction. In sympathetic nerve, the origin is from superior cervical ganglion, and then its target is from the dilator pupillary causes mydriasis, where the pupil dilation. In sensory, via long ciliary nerves, branches of trigeminal nerve. Functions of iris: regulates retinal illumination and controls the amount of light entering into the eye, and adjusts the pupil size for the depth focus, very important for the NIA task. Maintains aqueous humor circulation between the anterior and posterior chambers and protects the retina from the excessive light and glare. So next we are moving on to the ciliary body. Ciliary body is a forward continuation of choroid at oris aorta. In cut section, it is a triangular in shape. The anterior side of the triangle forms the part of angle of anterior and posterior chamber, and its middle iris is attached. The outer side of the triangle lies against the sclera and with the suprachoroidal space in between. The inside of the triangle, it is divided into two parts. One is an anterior part, where having a finger-like ciliary processes called pars pellicata, and posterior smooth part is called as pars plana. The microscopic anatomy of ciliary body. The ciliary body is a ring-shaped structure located behind the iris and in front of the choroid, and it is about 6 mm width and consists of two regions. One is pars pliccata, another is pars plana. Here, the pars pliccata is the anterior folded region containing 70 to 80 ciliary processes which secrete aqueous humor and serve as an attachment points of the zonules of cells. In pars plana, the flat posterior region is avascular and commonly used by surgeons to access the eye for procedures like pars plana vitrectomy. The microscopic anatomy of ciliary body. The ciliary body has several layers: supraciliary cillaries, ciliary muscles, and ciliary stroma, ciliary epithelium. So here, supraciliary is the outer loose connective tissue layer allowing the fluid to pass. So the ciliary muscle is composed of longitudinal, meridional, circular fibers. So these fibers alters the length, curvature, and to allow for accommodation for near work. So the innervation here is parasympathetic third cranial nerve to the ciliary ganglion cells. In ciliary stroma contains blood vessels and nerves, and in ciliary epithelium double layer. It is a double layered outer pigmented epithelium and inner non-pigmented epithelium. In outer pigmented epithelium, it is continuous with the retinal pigmented epithelium, which is RPE, and provides a structural and metabolic support. In inner non-pigmented epithelium continues with neural retina, and its function is to an active secretion of aqueous humor and components of the vitreous. The blood supply of the ciliary body is derived from anterior ciliary arteries and long posterior ciliary arteries, and these from a major arterial circle of iris, from which the branches supply the ciliary processes. In nerve supply, it has three nerve supplies: parasympathetic, sympathetic, and sensory. The parasympathetic nerve supplies are from a third cranial nerve, and it controls the ciliary muscle contraction and accommodation. And in sympathetic, it provides vasomotor control of the blood vessels. In sensory, it's via long ciliary nerves. It's the branch of ophthalmic nerve division of cranial nerve 5, fifth cranial nerve. Functions of iris. The accommodation of ciliary muscle alters the lens curvature for the near focus. Aqueous humor secretion by non-pigmented epithelium. Maintenance of the blood aqueous barrier via tight junctions in ciliary epithelium. And zonal fibers with suspensory ligaments of the lens arise from the ciliary body. Next, we are going to move on to the structure choroid. Choroid is the posterior most part of the vascular coat of the eyeball. It extends from optic disc to the ora serrata. Its inner surface is smooth, brown, and lies in contact with pigmented epithelium of the retina. The outer surface is rough and lies in contact with sclera. The microscopic anatomy. The choroid is the posterior vascular part of the uveal tract, and thickness is about 0.22 mm posteriorly and 0.1 mm anteriorly, and it appears dark brown and black due to the abundant melanocytes, which prevent the light scatter. So, in microscopic anatomy of the choroid, we have layers: the suprachoroid and hallux layer, stratus layer, and choriocapillaries and Brooks membrane. And the same topic will be discussed in the next session. So functions, functions of choroid is nourishment of the outer retina and supplies to the RPE and photoreceptors, and light absorption, this prevents the reflection and the scatter due to the melanocytes, and thermoregulation, which maintain the retinal temperature, and the pathway of the vessels and nerves supplying to the intraocular structures. So now we are going to see about the physiology of the uveal tract, the iris, regulation of the pupil size, meiosis and mydriasis. Meiosis is responsible for constriction and mydriasis is responsible for dilation. Here, meiosis is mediated by a parasympathetic nerve system, which is responsible by the third cranial nerve, occurs in bright light and during accommodation reflex. And mydriasis by sympathetic system via superior cervical ganglion, which is the dilator pupillae, which is responsible for dilation of the eye pupil, occurs in dim light, fear, or pain. Controls the depth of focus by altering the pupil aperture and protects the retina from the excessive light exposure. Ciliary body, it is responsible for the accommodation, aqueous humor production, and blood-aqueous barrier. The accommodation, the contraction of ciliary muscle, it leads to relaxation of zonular fibers, and it changes the lens curvature, increases, and the focus of the focuses on the near objects. So in aqueous humor production, the mechanism is an active secretion and ultrafiltration and diffusion across the non-pigmented ciliary epithelium. In blood-aqueous barrier, the tight junctions in the ciliary epithelium prevent the leakage of plasma protein into aqueous humor and maintaining the optical clarity. In choroid, the physiology of choroid, the nutrition of the outer retina, light absorption, and thermoregulation. So here in nutrition of retina, it supplies to the RPE and with photoreceptors via choriocapillaries. In light absorption, the melanin of the choroid absorbs this ray of light and improving the image quality and visual acuity. In thermoregulation, its rich of choroidal blood flow helps in heat dissipation and from the metabolically active retina. So we are going to move on to the general basic congenital anomalies of uveal tract. So here we see about heterochromia of iris, keratoconus, polychoria, and congenital aniridia. So for heterochromia of iris, the variation of iris color, the heterochromia iridum, the one iris differs from the other. So it would be different from each other, and heterochromia iridis is one sector of iris is differ from the rest. So the keynote of the heterochromia iris is you must differentiate from acquired causes and heterochromia cyclitis, Horner syndrome, iris melanoma. Next is about keratoconus, the abnormal or eccentric placement of pupil. Normally, the pupil is slightly nasal to the center. Polychoria, a presence of more than one pupil, may be associated with visual disturbances. Congenital aniridia, the congenital absence of iris. True aniridia is a complete absence, which is very rare condition, and usually a rim of iris persists in clinical aniridia. It is associated with glaucoma, angle anomalies, and zonals and ciliary processes are often discussed. Persistent pupillary membrane, it remains the fetal vascular sheath of lens. So next is congenital glaucoma of uveal tract, localized absence of tissues like iris, ciliary body, and choroid. The typical coloboma is the infronasal quadrant due to the defective closure of embryonic fissure. Atypical coloboma is in other quadrants, usually it is incomplete. So some of the disease conditions are anterior uveitis, cyclitis, and iridocyclitis, where anterior uveitis, it is an inflammation of uveal tissue from iris up to flash placata of the ciliary body. It may be subdivided into iritis, iridocyclitis, and anterior cyclitis. In iritis, in which the inflammation predominantly affects the iris. In iridocyclitis, in which the iris and flash placata part of the ciliary body is equally involved. In anterior cyclitis, in which the flash placata part of the ciliary body is predominantly affected. So iritis. Inflammation of iris, the anterior part of the uveal tract. And etiology is idiopathic, trauma, infection, and autoimmune systemic diseases and drug-induced. So, autoimmune systemic diseases are like juvenile rheumatoid arthritis, Beckett diseases, and drug-induced are drug-induced. In pathology, infiltration of inflammatory cells in iris and stroma, exudation in an anterior chamber, plate cells and hypopyon, and synechia formation due to the fibrous exudate. And clinical features, symptoms are ocular pain, photophobia, redness, blurred vision, and lacrimation. Signs. Some of the signs are irregular pupil due to sphincter spasm, an aqueous flash and cells, keratic precipitates, and posterior synechia, and iris is muddy or swollen. The treatment plan is cycloplegics, mydriatis, and prevent synechia to relieve the ciliary spasm, and topical corticosteroids, systemic corticosteroids, and treatment underlying cause for the dark glasses for photophobia. Complications are posterior synechia, secondary glaucoma, cataract, and chronic and recurrent anterior uveitis. Next is cyclitis. Definition in inflammation of ciliary body, intermediate part of the uveal tract. Etiology is extension of iritis, rarely isolated, and infective causes TB, syphilis, and viral infection. It is an autoimmune disorder and trauma, postoperative inflammation. In signs and symptoms, similar to iritis but more severe, pain, redness, photophobia, and decreased vision, tenderness on the ciliary body region, flares and cells are more marked, vitreous opacities may be present, and hypotony due to reduced aqueous secretion. Pathophysiology is congestion in cellular infiltration of ciliary body, serous into anterior chamber and anterior vitreous, damage to the ciliary epithelium, which is decrease in aqueous production. For treatment, same as iritis, cycloplegics, topical steroids, and systemic therapy is being given, and systemic immunosuppressants if associated with systemic diseases, and treating the underlying infection and systemic disorder. The complications are hypertony, which leads to thesis bulbi if it is chronic, and secondary glaucoma, vitreous opacities, and cataract. The last disease is iridocyclitis. Definition is if the inflammation of iris and the ciliary body together, the most common form of anterior uveitis. Since the iris and ciliary body is closely connected, they are usually inflamed together. Etiology is same as iritis and cyclitis, idiopathic, trauma, and infection and autoimmune diseases. In clinical features, the signs and symptoms are acute onset of pain, photophobia, redness, watering and blurred vision, and circumcorneal congestion, and small irregular pupil, sluggish reaction, flares, cells, and hypopyon in anterior chamber, posterior synechia formation, tenderness over the ciliary body, vitreous involvement in some cases. In pathophysiology, the cellular infiltrates in iris and ciliary body, exudates in anterior chamber, and flares cells and hypopyon, posterior synechia plus pupillary block risk, and the ciliary body dysfunction in which there are decreased aqueous production and hypotony, which leads to hypotony. The treatment is cycloplegics and mydriatics, example atropine, to relieve pain relief and prevent the synechia. Topical steroids and frequent instillation, systemic corticosteroids for severe and recurrent cases, immunosuppressives, and treat systemic and casual diseases, and control IOP if raised with anti-glaucoma drugs except miotics. Thank you. Thank you, ma'am.
Thank you so much, Rakshitha. It was a complete overview about iris and ciliary body. Now I request our moderator to add your clinical inputs, ma'am.
It was a very in-depth presentation. I think you have covered many of the important and additional points into the anatomy and the clinical pearls related to the iris and the uveal parts. So for me, I would like to add a few of the points which she has covered in the clinical conditions. So you have mentioned about, I think the heterochromia you have mentioned. So, heterochromia is usually occurring. You have also mentioned about how to distinguish it from the Horner syndrome, also. So, the basic difference in the heterochromia in Fuchs uveitis and Horner syndrome is that in the Fuchs uveitis, mainly it is because of the your anterior layer or of the iris is absent usually in the areas, and that leads to the heterochromia in the, which is the main part of the color presenting the color of the iris, and if that layer is missing, and that is leading to heterochromia in the Fuchs uveitis. But in case of your Horner syndrome, what is happening is the sympathetic innervation that is there in the pupil. So the sympathetic innervation gets affected, and because of that, the melanocytes which are there in the pigment epithelium are not getting migrated towards the iris, and that is the reason of the heterochromia in the Horner syndrome. So that is the basic difference of the heterochromia between Horner's and the your Fuchs uveitis thing. And also, in addition, I would say that all this anatomy of the uveal parts which you have covered is has many other aspects as well. So for which we need to know about these parts. That is about the post-surgical complications and during the surgery complications, like in cataract and glaucoma. So main in both the surgeries or in ICL surgery or ACIOL fixated ACIOLs. So basically in all these conditions, what happens is the eye gets into, and during the surgery the eye gets into a hypotonic condition, as you have mentioned about hypotony. So the eye gets into the hypotonic condition during the surgery or even sometimes post surgery in glaucoma, and that will obviously reduce the angle of anterior chamber, and then finally it may also have a prolapse of the vitreous. You have also shown that this all conditions further, what happens is they increase the choroidal effusion. So in the subchoroidal space between the sclera and the choroid, the space which is there usually remains blank or dry because of the hydrostatic and oncotic pressure. But during the hypotonic conditions, sometimes the vessels which are there in the subchoroidal space may have leakage or hemorrhages, leading to choroidal effusion, and also there can be some pigment distortions in all these surgeries. The pigments get released in the iris from the iris, and due to continuous friction of the iris and the lens, there can be secondary glaucoma or pigment dispersion related glaucoma, which is very common in post surgery as a post surgical complications in the ICL and ACIOL surgeries. So that is something additional that I would like to add. Yes. Any questions if there, I can take off.
Thank you so much, Roshni, ma'am. There is no questions as of now. Let me check the live, ma'am. Meenakshi, can you please check and let me know whether there are any questions in the live?
Just a minute, Gomati. Am I audible?
Yes.
From the disease perspective, we do have one question from the student, ma'am. I'll read it out for you.
Yeah, sure.
How could we differentiate between granulomatous and non-granulomatous uveitis, and what is the role of corticosteroids in managing anterior uveitis?
Okay. So corticosteroids, as she has mentioned, is mainly helping us in reducing the inflammations and also inflammation mainly. And in case of uveitis for granulomatous and non-granulomatous, mostly is as per the clinical features if concerned. So obviously there will be the different in the and in if I see the iris or the cornea, there will be in the iris we will see the granules present in the granulomatous uveitis. And other than that, the pain and the other symptoms and signs related to the circumcorneal congestion and all will be present in both. But mostly, yeah, this.
Thank you so much, ma'am. One more question to add it up. How would we approach a systemic workup for the patient presenting with anterior uveitis?
So systemic workup, we should look into the mainly the systemic associations. Like we know that tuberculosis, rheumatoid arthritis, and many autoimmune disease may link up to the result in the uveitis. So during our optometric workup, we should look into the proper systemic history, and also we should record if any blood test has been done. So for HLB27 and other blood tests which are important indicators for these diseases. So we should look into those factors and record those during our history taking and other so that we can have an early diagnosis of the uveitis during workup.
Thank you so much, ma'am. That's all with the questions as of now. Gomati, over to you.
Thank you so much, Meenakshi, for the Q&A session. And Roshni, ma'am, thank you so much for joining with us today, ma'am. And thank you for answering for the questions as well. Thank you, ma'am. We'd like to host you on another wonderful platform, ma'am.
Sure. Thank you. Looking forward.
Yeah, thank you. And Rakshitha, thank you so much for presenting. It was a wonderful presentation, Rakshitha. And dear audience, thank you all so much for your continuous support towards Optometry series. I got a couple of announcements for this particular week. Masters in Optometry admissions open at Dr. Agarwal's Institute of Optometry. If you want to know and if you want to apply, please click the link given in the description box. And most important of all, ISVTech, the collaboration conference with Laila Icahn College, is also happening in the month of October on 24th and 25th. So if you like to register or if you want to know more about the bulk registration, please contact Ms. Bhargavi. Her number will be given in the description box. Meet you all in the next episode. If you like this video, give a thumbs up and share with all your friends. Thank you all. Thank you so much, ma'am.
Thank you, ma'am.